at this? Okay, perfect. Then this will be really easy. Okay? Second thing we're talking about is evidence-based public health. So we're going to be talking about what is evidence, how do we use evidence, how do we collect evidence, what does it mean, how do we sort of go about using quote-unquote evidence to inform public health policies, decisions, all those types of things. Who read the 2 papers? Who's lying? Yeah, go ahead online. Did someone raise their hand?
Sorry, I meant to say yes, I did.
Okay, perfect. I can see you in the chat room, so just chat. Chat is your default. But you can raise your hand, that's good. Okay, so basically what we're going to do today is, I'm going to talk a little bit and then you're going to do a lot of work. So we're going to talk about strategies to read, critique, and complement academic papers. Okay. One of the things that you learn really early in your undergrad and most of your master's training is how to just rip a paper to shreds, right? And it's really easy to just go really picky on the methods and say, no, this is wrong, this is wrong, this is wrong, this is wrong, right? It's a little bit harder to say, well, what's good about this thing? Why would some journal publish this paper? Obviously, someone thought, yeah, this is good enough that it should be published. So how can we sort of try to pick out those compliments, those good things about papers? And also, we're going to talk about how to read and critique papers. So who thinks that they did active reading when they read their paper? How long did it take you to read the paper that I wrote? 20 minutes? Who skimmed? Who skimmed the methods? I skimmed the methods. Okay. Who skimmed the discussion for conclusions? Who skimmed the intro? So like, I don't need the intro. It's just fluff anyway, just to get me to the method, right? Okay. So one of the key things about reading and critiquing papers, you need to be active reading. That means focus. I listen to music. You can listen to music if you want. I don't care. But really try to read and concentrate on what you're reading. Concentrate on the sentences. Concentrate on the structure of the paragraphs. Concentrate on how the literature review fits with the research question, fits with the methods, fits with everything else. Don't skim. Read the methods. Even if it's like advanced epi, biostat stuff that you have no clue, suffer through. Try to focus and read the methods. Because you will learn something at the end of the day, right? You will have an epiphany about logistic regression or something funny because you sort of suffer through these long and dry method sections. Some other things that I find really helpful for myself, okay? Relate what you're reading to your own work interests. Now, my paper that I submitted is on the impact of a bike share program. Who cares? Who has a public health interest in cycling and transportation and physical activity? Yeah, maybe like, I don't know, 5% of the class, 10% of the class. The rest don't really care, but that's okay. How could you think about how the work that I was doing would relate to your own interest in public health? Who has an interest in public health intervention, broadly speaking? A couple more people. Okay. Who has an interest in population health research methods? 2 people. Yeah, research methods is kind of boring. So think about how you can integrate the paper that you're reading into your own work. Dr. Froehlich's paper, Kate's paper. What was she talking about in that paper? Not all at once. Yeah. So, social determinants of health and health inequalities. Okay? It's not a methods paper. It's not a sort of standard, design analysis kind of paper. It's an argumentative paper saying, look, something is going on here. It's a criticism of what? What report is she sort of talking about criticizing? Not all of them. Exactly, WHO Commission on Social Determinants of Health. So she's trying to get us to think about that report in a different way. So how could that apply to our own work, right? How do you think or write the way that Kate does in terms of argumenting something like that? It's really hard. It's hard to, this big report on social determinants of health comes out, all these sort of bigwig public health people are, out there and promoting it and doing all these things, and there's sort of a prof sitting in her office going, yeah, this is kind of garbage. I think we need to think about this and this and this and this within this report. That's hard. So think about how you can do that with your own work. What is it that needs criticism in your own areas of interest, vaccinology or epi or whatever? Who's seen this before? Pico. Okay, so this is what the med students use for their intro epi class, and it's sort of the med students' guide to how to read a paper. Population, intervention, / exposure, control, and outcome. The first thing any med student does when they read a paper is they write those things down on a piece of paper. What's the population? What's the intervention or exposure? What's the control? And what's the outcome? Why might this be useful? Why would you do this or not do this?
Well, it really simplifies who you could translate that information to. So the population is a job type women. I could then take this information and use it for the next woman. And then it makes it nice and pretty in terms of what they did and who they did it to, who they did it to.
Okay, so exactly. So one of the ideas is that it makes it more usable for us. We can generalize to we can try to look at whether that study is generalizable to a population that we're interested in or not, and how we might apply that information. The other thing is it organizes us really quickly. What's the outcome? What's the exposure? What's the population? We just sort of go through the paper and go, okay, this. These are them. And sometimes it's not obvious. When I do this with the med students, we do some on exposures and some on outcomes, and we literally sit there for 5 minutes reading the 2 lines about the exposure going, I have no idea what they're trying to do here. Right? So sometimes it's obvious and sometimes it's not. That questioning or that thinking around that exposure or outcome or control helps us with our critique. Because if we can't even figure out what the outcome is, how do we trust the results of that paper? Right? So that's our reading paper. I recommend that you use the PICO. So population, intervention, exposure, control, outcome. Just go there. Okay? And then how do you critique a paper? Give me some hints. What do you do? What's good, what's bad? How do you know?
You can look for bias.
What kind of bias? But it's for online, so it needs to be loud. What kind of bias? What kind of bias?
Well, any kind of bias, so like whether the researchers are conflicted or whether their population is conflicted, or it depends on what the paper is.
Okay, so it depends on the paper, but just all the bias. We're just finding all the bias. What else can we do? Yeah.
And see if they've reported any limitations, whether they acknowledge it.
Okay, so whether they actually talk about their limitations in their limitation section? Give one? No? Just looking very intently at me?
I learned a Nature a couple of months ago that you find a research question and then you design your ultimate perfect study that you would run if you had no limitations, no resources or time or ethics, and sort of go through what would be your priorities and how you would control your biases. And then contrast it against what they did, because they had a reality to work with, and then if the choices they made sense considering your circumstances, then you can give them a check mark, but if it was like, you're really copying it, you can do better, then you can.
Okay, good. So basically imagine that there's no limitations to your study and just design the best study with a similar outcome, similar exposure, so on. Lots of people call that a thought experiment, right? Do a thought experiment on the ideal study in an ideal world, and then say, okay, what limitations do they have? Funding, population, recruitment, so on, and are those reasonable limitations? One of the big ones that I think is often missing is a research statement or hypothesis or research question. Okay, what is the research question? Does it make sense? Does their study actually answer that research question or statement? Right? Lots of times you see a study and there's no real research question, there's just lots of results are getting spit out and you're going, well, what's going on here? I'm not sure what they're trying to do in this study. So really clear research question, research statement, and hypothesis is going to help a lot in you understanding whether this is a study that's following some sort of logic. Second thing, which was pointed out, do the authors suggest their limitations? Do they actually give you some of their major limitations in their stat section? Right? It's going to give you some idea of, well, at least they're honest about what they can't do. And they're saying, look, this is our limitations. We don't know what else to do about these. Here are maybe some suggestions. And can you add to the limitations? Are there obvious limitations that the authors didn't put in? I can guarantee you that if they didn't put them in, they thought of them, and they're like, no, they're just not going to put this in. It's too big of a limitation. We don't want to put it there, right? And your job as a critical reviewer is to say, no. You listed 5, but the big one isn't in there. And you'll see that all the time, right? You see that in lots and lots of papers. And then one of the crucial things I think for all of the study review that we do is, what's the number one limitation? It's really easy to list off like 20, right? You guys are probably really good at that. Give me every single limitation. List off all the sources of bias and how they were not addressed in the study. But when it comes down to it, there's usually one that's like a killer. One limitation that kind of goes, no, this makes this study either reasonable because they've kind of dealt with the limitation, or no way, this is no good. Okay? So that's what I'm going to challenge you to do today, is think about, don't give me the list of limitations, give me the number one reason, the number one limitation, and why, because that's the number one limitation. The other thing you can do for your study design or your study critique is look at research statements. Has anyone heard of sort of research statements, consort or strobe? There's also trend, there's a whole bunch of them. Has anyone heard of these things before? Not very many, a few people. Okay, so consort is consolidated standards of reporting for trials. So this is reporting guidelines for randomized controlled trial designs. Okay, basically it's a 25-item checklist that says, if you're reporting a trial, here's everything you need to report on. Okay, strobe, strengthening reporting of observational studies in epidemiology. These are for your ecological, cross-sectional, case control, and cohort studies. It's a 22-item checklist, same thing. Do you actually give me all the information I need to properly evaluate the study? Trend is something about non-randomized experimental studies. So basically, if you have some kind of experimental study that's non-randomized, how do you report that? So you can use these guidelines as sort of a fallback for evaluation. So this is just a sample from Consort. Identification as randomized control trial and title. The background, scientific background and rationale, specific objectives or hypothesis. So this is exactly what I was talking about earlier. Strobe in the methods. Describe the setting, location, and relevant dates, including periods of recruitment, exposure, follow-up, and data collection. Do they have all those in the paper? For a cohort study, do they get eligibility criteria and methods of selection? Do they describe methods for follow-up? Do they do all of these things that we need to know to evaluate a study? Last thing, complement. How do we complement the study? So I'm going to say that there's 3 things. What advances the literature in the paper? That's sort of the idea, right? Standing on the shoulders of giants, we say, okay, one publication leads to a new little idea, someone else publishes something on that next little idea, and then the next, and then the next, and then the next. So what about that paper advances the literature? Either in sort of an argumentative paper, how we think about something, or in a more methodological sort of standard paper, how we build on past literature. So is there a specific thing in that paper that advances the literature? When I was in my master's, we had to, whenever we discussed a paper in class, we had to either say contribution to the literature or pile. Does it just get added onto the pile of junk that we don't need any more studies on, or does it contribute to the literature? With every paper that we read, we had to give that assessment, pile or contribution to the literature, along with all our other assessments. Okay? And then the second thing, what can you use from the paper to advance your own thinking or work? So what is interesting about this paper that maybe you hadn't thought of? Or what is this paper getting you to think about that maybe you haven't thought of? Okay, so that's exactly it. How can you stand on the shoulders of giants? How can you build on your own work, right? It's going to help if you've not skimmed, if you've done active reading, if you've been focused while you're reading this. And then the third thing, what inspired you about this paper? I'm making you read them, so they're probably not that inspiring. But when you get to read for your own work, why is it? Was there one sort of paper that kind of makes you go, oh my God, this is so interesting. This is why I want to pursue logistic regression for the rest of my life, right? Somebody who's doing biostats had that revelation at some point, right? For me, it's like I read this paper on transportation and public health, and I was like, oh my God, this is amazing. I want to do this for the rest of my life. So that's kind of what I'm doing now. So how do you get interested and excited about an academic paper, which oftentimes lots of people aren't? Okay, so class assignment for today, we're going to do this twice. So first with the paper, my paper. So not in groups of 3, in groups of 5. Okay, You have 20 minutes to discuss first my paper, okay? List the 3 best points of the paper, the 3 most important limitations in order, and why. Okay, so not only the 3 most important limitations, but why those are the 3 most limitations, and why 1 is more important than 2. And 3 suggestions for improvement. So how can we improve this study? All right. So this is exactly like that thought experiment. How do we improve on the study, or how would we redesign the study to make it better? Okay. It's exactly our sort of thought experiment idea. Ready? Go. Groups of 5. Sorry, just one more thing. The reason I submitted one of my papers, it wasn't to be like, wasn't to gloat, but was to give you the opportunity to 2 things. To give you some insights into the things that happen behind the scenes in papers that you don't know about. Like, there's some that you'll pick out, hopefully that I'll talk about, okay? But also to give you the opportunity to ask me questions or whatever. And lastly, just go for it. Like, this is a class where we're supposed to discuss, we're supposed to think, we're supposed to, you know, actually just debate public health topics. So I'm here, and be critical. Rip it apart.
I don't know if you can really look at we did not include the we kept in very low numbers that were
But they do say have a higher rate of and then after it, so there's a non-relevant. Right. So, and that so then again, that's so I think that's pretty good. Area and by
What's going on here? Right, so there's like some.
Yeah.
So it's pretty good. Pretty good price. Okay, good. What else?
And we said that it was we have collection lab, it's not like capital, and then
Okay.
so
Okay, good. So yeah, the
like you guys see how much we're just trying to figure out which one.
good. Keep going. Another guy.
We got to red white. Well, they do professional, but they do before and after. So they have 3 sites, then season 1, and then they do the sample there, and then they do one, and then they do it again, and then they add another. So it's kind of like this is perfect. But it's exposure, not exposure. It's like they're trying to do homework.
But basically, there's always 70% full style.
That's the greatest part. But nowadays,
Yeah.
Well, we found the models in all of the so James' our ability.
Of the people that are already
Okay. So,
well, then there's definitely more reason, right? What's the standard of BC? Or then published with it? Like, they sort of
Okay, everyone, so we have 4 more minutes. Remember, I want the 3 best points, 3 most important limitations ordered, and 3 suggestions for improvement. 3 minutes. Get something down.
Lecture, but I'm just saying that for in areas like right now, we did it for 5 years. Like, have a lot of it there. Like, I mean, it's not why I'm good at it, but I just would be the numbers are a little bit higher than what they putting these documentations have abundantly in all neighborhoods. I don't know, I just feel like maybe the numbers are a little bit higher yeah, it's showing the like I think people are it's not like a style most of the time it doesn't mean come right away. You must start wearing those things or I will see your desire
Then would you say, like, a lot of
yeah, because that's
if you went back in at a small scale, you need
Okay, one more minute.
like levels of like
Okay, folks, that's time. Come back. Come back. Hello. Okay, good. Got it? Just gonna wing it. Okay, perfect. Okay, so was that hard or easy? Hard. You just spent almost 25 minutes talking about one single academic paper. Seriously. But that's the level of detail that we need to get at when we really want to read a paper in depth. What you've just done is sort of starting to get at the level of detail that we want to start thinking about when we're thinking about that, right? Because in your specific area, that's what you need. That's the level of detail that you need to read papers with to really be critical, and in my opinion, to really think about like novel, interesting study ideas for what's coming next. Okay, lots of people were talking about it would be cool if we had a map of the stations. I just pulled it up. This is the actual website of the company. So those are all the stations. This is more stations than there was in 2009, 10, 11 when the study was done. So it used to end kind of here. There was no stations after that. Well, some stuff forward. But someone touched the board, bad things happen. Okay, so yeah, there was fewer stations now. The program's gotten a little bit bigger. Okay. So when we're thinking about our 3 questions, let's start with What were they? What was the first one? 3 good things? What do we like?
Positive results.
Good. Okay, good things. Yeah, we got positive results. This is really weird to write with. So what's important about positive results?
I disagree that positive results are important. I think having results are important, but it shouldn't matter whether they're positive or negative, as long as they add to the body's knowledge.
Okay, right. So there's an argument about the results shouldn't matter. It should be, does it contribute to the literature? But we know that there's this thing called publication bias, which means papers with positive results tend to get published more. So if you have a positive result, that's probably a good thing for getting your paper published. But it doesn't mean that it's a good thing for science. It's a bad thing for science, right? So there's sort of this juxtaposition here between the positive results and the fact that the paper was published. What else do we like?
We like that they use the well-validated IPAC tool, so it's previously established.
So validated outcome measure. Okay, what else? Large sample size. Okay, this is horrible, guys. I start writing like this. If I can. Large sample. Why is that good? Why do we want a big sample? Sorry, what?
Power.
Power, so it gives us some more power. Okay, why is power important? Why do we want power?
Well,
So your result is less likely due to chance?
So a result is less likely due to chance? Probably a good answer. Okay, or so that we can, at least so that we can understand chance a bit better, right? What else is good? What else do we like? Sorry, what? Okay, so detail in terms of control variables or controlling for confounders and sensitivity analysis. Somebody talked to me about sensitivity analysis. A couple of groups I talked to it with. What was the point of that sensitivity analysis? What was our primary outcome in the paper?
10 minutes.
What, 10 minutes?
Exercise or cycling?
Cycling for at least 10 minutes a week. Okay? So that was our primary outcome. Any cycling for at least 10 minutes a week. Is there any public health relevance to cycling for 10 minutes a week? Is that going to increase population level physical activity? Probably not. No. Okay. But it was sort of the background story is that if you've seen the actual continuous data of minutes of cycling per week in the sample, basically it's like 90% 0 and 10% of the sample 10 minutes a week or more. So we just said we want to try to include as many people as we can. Challenging to model all those zeros. Let's just make it logistic 10 minutes or more. And then let's do the sensitivity analysis to say, well, could there be a public health impact on physical activity? Let's say 30 minutes a week or 45 minutes a week. So what's our public health recommendation for physical activity? How many minutes a week? 150 minutes a week. So if we say, well, we still get the same result or a similar result at 45 minutes a week, that's about a third of our, about a fifth of our physical activity guidelines. So, that's reasonable. That might have an impact on population level physical activity. Anything else that we like?
I'm kind of going back to the large sample. We like that in table 1, there was kind of an outline that you had done a predictive of what the sample size would be like, so you can see whether or not it's adequately representing the population.
Say that again, sorry?
With table 1, with the predictive that you took the census and tried to see what age group this area would be, you can kind of see that you have an adequate sample representation.
Okay, good. So let's springboard off that to limitations. What's the primary limitation? Lots of whispers of selection bias. Who has selection bias? Okay, who figured out that they were talking about selection bias and didn't use well, they just sampled landlines. That's bad, right? lots of groups said that. Lots of groups said, well, I understand that it's not good that they only sampled landmines. But what I'm trying to push you to do is say, what's the epidemiological language for that? Why do we say selection bias? Why is it important to when you're speaking in a public health audience, say, there's selection bias because they only sampled landmines. That's bad because here are the reasons that selection bias is bad. Right? Intuitively, you know that only sampling landmines is not good. But how do you attach your epidemiological language to that? How do you attach your biostats language to that? How do you attach your public health language to that criticism? Okay. So what happened? What's the result essentially of the only sampling landmines? What do we get? What happens to our sample? Okay, it tends to get older. Older people more likely to have landmines, right? What else does it get? More female. Okay, so there's more women. Why? That's true, but what else? That's not the reason, though. That's not the reason. They answer the phone. If a man and woman are at home, the woman is more likely to answer the phone. Okay? How do we try to get around that? Exactly. So the person, the interviewer says, could I speak to the next person to celebrate their birthday? But it doesn't matter who answers the phone. It matters who the next person to celebrate their birthday is. That being said, we still chose, if the next person to celebrate their birthday wasn't there or wasn't available or whatever, we still talk to the person who answered the phone. So we end up with more women. Okay, so does our large sample fix our selection bias problem? No. Okay, so sample can be as big as we want it to be, we still have selection bias happening. All right, what do we do in the paper to try to fix our selection bias? Methodologically, after the fact. Weighting. Weighting. What is that? What do we do? What do we do with the weighting? Okay, basically, the weighting, we're trying to correct the fact that we have too many old people and too many women. So essentially, it's a really simple calculation that we take the census data, which we assume is the most accurate data we have on age and sex, and we just correct our sample. We multiply by some fraction, some factor, right? So the men in our sample, all of the men's results would get multiplied by something like 1.17. Because we want the men to be a little bit overrepresented. And all of the younger people, they would get, their results would get multiplied by 1.13 or something. So that they're a little bit heavier, they represent more. So we're trying to make it look like we have a census. So this is sort of a post-hoc way, after you've collected analysis, that you can try to fix your selection bias. It doesn't fix it, but you try to get you there. Okay, what's another limitation? Yep. Okay, so the comment was that essentially the comment is that cycling might change because of some other factor other than the program itself, right? We might have, for example, lots of new bike lanes put in Montreal that might increase the amount of cycling that we have. We might have some massive viral social media campaign that would increase the amount of cycling that we have. We might have all of these alternative explanations that could explain why cycling increased. Okay? Do you buy that? Do you think that could be the case? Yes? Everyone? Yeah. Okay. This is one of the things that as a group, in doing this research, we really, really struggled with. Because obviously the bike share program itself isn't just whether you live close to a station or not. Like there's a whole social media campaign, there's all of this media attention that goes into the program itself. Our exposure is just, do you live close to a docking station, essentially. But there's all this other stuff that we don't take into account that should probably be counted as exposure to the program. That we're just like pretending isn't there, going, no, we don't know anything about social media, right? So that's something that's really, really sort of not well taken into account in our study, okay? The other point about sort of infrastructure or other policies or programs, it's possible that a program like a bike share program might interact with, for example, cycling infrastructure. So it might be that in order for a bike share program to work, you need to have lots and lots and lots of bike lanes already there, which Montreal already had, right? One of the groups was talking about generalizability to Canada. They were saying, well, this is only generalizable to Montreal. It's not generalizable at all because it's only specific to Montreal. You can't take it to Toronto or other cities that might have bike share programs. That's totally true. We just said, when we say it's a case study, it's just like, this is what happened in Montreal. What we might want to know is, does it interact with different types of policies in other cities? The mayor of Boston said that they were going to get a public bicycle share program, but he also said, not until we have 200 miles of separated bicycle tracks in Boston. Because his thought was, well, the bicycle share program's success is going to interact with the number of existing cycling lanes, and that's important. What about helmets? Vancouver's supposed to get a bike share program, but they have a helmet bylaw. You have to wear a helmet when you're at a bike. They've been working for 4 years to try to get a program implemented, but they just can't figure out how to do the helmet thing. How do you do the helmets? Do you give everyone a helmet? Do people share helmets? Public health implications of that, right? Does everyone have to buy a helmet? They just can't figure out how to solve this helmet problem, so they haven't implemented the program. So that essentially would be sort of an interaction, right? It's the program, the implementation of the program itself, interacting with something that already exists in the environment that might change our result. Yeah. Sorry. I forgot about this.
This would be a limitation, like if you are calling people who might not be aware of this program, would calling affect the way would it act as a promotion? Like let's say they didn't know about it and you're calling to expose them. So when you measure it in the second piece, more people are aware of it just simply calling.
Right. So that's what's that called? That email is going into that. Anybody? There's lots of different terms for kind of the same thing.
Kind of like observation bias?
Kind of like observation bias, kind of like a white coat effect or a lab coat effect, right? We're calling people and we're saying, hey, have you heard about this Dixie thing? Blah, 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 blah. And then we're telling them about the Dixie thing. Well, yeah, they've heard more about it. Actually, what we did in the survey that you don't know is that we never actually, we asked all of the cycling and sort of demographic questions before we asked about the bike share, or before we even mentioned the bike share program, because we wanted to try to limit that lab coat effect in the sense that we wanted them to answer all their questions about their behaviors before they got a hint that we were actually trying to study the bike share program, right? So that's one way. Another way to do that is that's actually one of the reasons why we did a repeat cross-sectional sample instead of a longitudinal sample. So one of the groups said, well, why did you do a longitudinal study instead of this repeat cross-sectional? Obviously, in terms of causality, our longitudinal study is a lot stronger. But that's one of the big problems with a study like this and a longitudinal sample is, as soon as we recruit people into the sample, we have to tell them that we're studying the bike share program, and we might have a big impact on their use of the program. So with our repeat cross-sectional study, we're able to say, in this population, in a different population, in the same population over time, what's happening, right? That's good. Okay, what would you improve? Yeah, hang on.
Just looking at the results section where it says the 8.5% of the response were really because of the statistical data. I read it last night and I wondered, was that a selection error or was that like a misplacement, or does that matter?
Do you think it matters?
Well, it seems like almost a tenth of your population got pulled out. So then, yeah.
So why would that matter?
Well, you're just removing results. But if it's just exactly for one item. Anyways, I'm just curious, like how that happened and the background in the background.
So the postal code question is a big one, and yeah, there's a lot of reasons why people mess up their postal code. Okay, because it's numbers and letters, a common thing is that you get replacement. So people replace zeros with O's, and they replace, you know, sixes with Z's, and they do all kinds of funny things with the postal code itself when they're being told. So that's our people on the phone answering the question. The other thing is people actually don't do a good job of remembering their postal codes, right? Even if it's like, what's the postal code at your house? People don't really know, right? Hang on. And some of our other work, we asked in the same questionnaire, we asked, what's the postal code at your workplace? It's like 40% of people know the postal code at their workplace. So we ended up just throwing all that workplace postal code data out. Nobody knew their postal code at work. Go ahead.
Since you're calling landlines, do you now have connected that to postal code?
It is possible, but that poses more challenge with your random digit dialing. So honestly, what they do with random digit dialing is they just dial 7 random numbers, and they don't connect like thousands of times, and then finally they'll actually hit a number. If you use the postal code information before to like preload the data, you're somewhat getting a less random sample because you already know the postal code information. It's also not necessarily accurate, right? That because you know the postal code, you know the phone number. So we just ask them their postal code. There's lots of other ways to get postal information, like what's your street intersection do you live on, what's your complete street address, but lots of people don't like giving that, right? That's sort of a sensitive question. What exact street address do you live at?
How do they miss cell phones then?
So why did we not sample cell phones?
So with the random dialing, how does that work? Like, if it's just dialing random numbers, how would it not come about cell phone numbers?
Okay, good question. What do you think?
Well, without knowing how the system works, I don't.
Three numbers are specific to landlines and cell phones.
Right. So sometimes the first 3 numbers can be specific to landlines or cell phones. So the big challenge with sampling cell phones is that it costs money to the user to actually talk to you on the phone. Most of the time, what people do is that they compensate the people who are speaking on the phone. So they'll say, you're going to answer a 20-minute survey, a 10-minute survey. You'll get a $5 credit on your phone bill after the conversation, right? Our budget didn't have enough money to do that, okay? So we were just like, no, we can't do that. Another challenge with the cell phones is that we did stratification by postal code. So we oversampled people in certain areas. And at this point, I don't know if it's possible to do that with cell phones in terms of pre-sampling. So you'd have to phone a cell phone and say, what's your postal code? Oh, sorry, no, you're excluded. See you later. Again, that costs a lot of money to try to do that. So we just didn't have enough money, basically. Bottom line. Suggestions for improvement?
Yeah, we said that you should look at the actual public health impact of the intervention. So if you just make people who already jog for half an hour every day cycle more, then that's cool, but you don't actually make anybody healthier, right?
Right.
Whereas if you make obese people who wouldn't have had any physical activity cycle more, then you might actually fix the lives.
Okay, so that's like a replacement versus addition question. Is it people who are already fit, who are just biking more and they don't really need any more activity anyway, they already get their 150 minutes a week, or is something else happening, right? The other things that we could think about, right? Well, are the bike share adopters now more exposed to collisions? They get hit by cars more. So maybe there's no net benefit. What about air pollution? Are they exposed to more air pollution, right? And what's the effect of that on public health? Sort of what we know from the modeling studies that have been done is that overall it's really beneficial to use active transportation, walk, cycle, take the bus, and the main benefit is from physical activity, despite increased risk of collisions, air pollution exposure, like weird urogenital tract infections and stuff if you cycle, like, you know, if you're a professional road cyclist, there's a weird stuff that happens. But generally speaking, the net benefit is positive, right? But that's true, we didn't do that, and actually we're doing it right now. Any other suggestions? Yep.
You also, sorry, not just in your conclusion, you stated that the numbers or likelihood increased, but you didn't tie that into how that how that relates to the actual goals of the PUBH840 program. So the real world sort of application of that, your findings, you know?
Right, exactly. So what would that look like? Like how do you think the program sells itself to the public? Do you think physical activity is one of its selling features? It actually is, but no, that's okay. So what else do you think it sells to people? Why would people use it? How are they selling this thing? It's convenient. A big thing is environmental impact. You reduce carbon, you save gas, you drive less, all of this. That's another big thing. Okay? So those are sort of the three selling points. And yeah, we don't tie that in at all. Really, we just say, this is our science, we don't care about what happens in the real world. We'll just do our stuff. Any other suggestions? No, there's a problem over there.
PubH840 you can gather points from message. Surveys and targeting most people for any other documentation.
Okay, good. So I'll do a question online first, and I'll come over there. Okay, so other data collection methods, what could we have done? We did two other kinds of data collection methods that aren't actually recorded in this paper. We did intercept surveys, so we actually stopped people at stations and had them answer a 5-minute question about their transportation behavior, where they're going, what they're doing, so on and so on. So we have a sample of, I think about 3,000 users over one summer, just an intercept survey. We also did a GPS cell phone survey with 57 bike share users and tracked all their movements for a week. Okay, that didn't go into this, but that's other types of data that we've collected. So yeah, it's really hard. One of the things that's really hard to do is tell a story about the whole thing in one paper, because there's a lot there, right? So one of the questions online was, this is Pamela. She says, not all weather variables are addressed. Okay, so what weather variables do we include in there? Average temperature and days of precipitation in the past week. So if it rained at all on one day, that's 1 out of 7. If it rained at all in 2 days, that's 2 out of 7. Okay. Do you think that's okay? Do you think that all the weather variables are correlated? Yes, maybe. What if we had included like adverse weather events? What if one day it was just ridiculous? There was like a big snowstorm and there was 2 feet of snow, and that sort of washed out the result for a whole week because it took 3 to 4 days to dig out all the snow and do all of that stuff. Right? That would be something that we could include, some kind of adverse weather event variable. Hours of daylight, that's what this is online here. So yeah, the number of hours of daylight. Daylight savings in Montreal is painful. It's dark at 4:15 in the afternoon. Okay? Could be one. Wind could be another one, right? So these are weather variables that we don't argue, but we imply in the paper that they're all correlated with one another. So we just put 2 in there and we're good. But you could argue, and people do argue, that that's not true, right? So these are things that we sort of have to debate a little bit. Good. Anything else to improve?
You just said that maybe we should look at a different non-exposure group, because your non-exposure group are just people that either answered the survey before the whole program was implemented or after it was just taken off. So maybe we should look at like a totally different community.
Okay, so what would so another community, so we could look at like Quebec City or something, to say that's another non-exposed group that we're looking at that has nothing to do with the intervention at all. What would that help us do?
And then supplement your concern about exposure, not just by proximity, but by advertising and discussions and things, because it's not in the vaccine.
Okay, so exactly. One of those things it would do is it would control for that sort of confounded exposure measure. It was confounded with social media and all kinds of other things. The other thing that it might help us do is control for secular trends. So, or control for those alternative explanations, right? What if it's the bike lanes? What if it's that social media stuff? If that's not happening in Quebec City, and we can show that there's no change in Quebec City, then we can say, well, this is not likely to be the case. It's not likely to be the case that there's an alternative explanation, possibly. Okay? That's a little bit harder. Okay. Great. Let's have a break. Come back in 15 minutes. Come back at 3 o'clock.
So the reflection part, that's like pass fail, is that
Then you get
my other question was for data split. Does it happen? Yeah, if I got 2 credits for
I think that's pretty good.
one week that I was every time we
Right. Sure. Okay. If you want to send me like a little blurb, just email me the top, like a tiny blurb, and then just like how you're going to structure it. These calls are going to structure it differently from what I have. So I can try to put something together that will value Right, okay, so you actually So what I'm going to do is, I think now we have everyone registered, I hope. I'll assign the people who haven't onto the group randomly to a group. So you won't get a choice of topic. You won't get a choice of group name, fortunately, but they've already started adding up to that choice of topic. That's going to be your lot in like a little bit. And then, yeah, that helps you set up. So this is what I have in the file. I'm getting a couple group names. You'll get added to a group. So, yeah, I just think so when I downloaded the list last Monday, you can register or I hadn't gotten so I'll add your group and then I'll send out the pages after class tomorrow. Yeah. Oh. You guys are well, I don't even know if they're yeah, no, I don't know. Sorry about that. Hi. Sorry, what's that?
Oh, I take my And my first mistake. Really? I can't.
It's all recorded online, you know. I watch the online thing. No, because I looked at the clock and it said that like it was from. I thought it was only on Thursday afternoon. No, it only goes from Friday on Thursday. You said that tutorial is only an hour and a half instead of 3 hours. Wait, we have to ask what the tutorial on Tuesday and class on Thursday is only I would think
there's 3 tables that have done that kind of now I guess either like your program or
it's just that I don't have to do, I don't have to do,
That's so funny. Oh, it's not there.
Like in 2 days? I have like nothing to add.
Yeah. We'll call it recording, right? The healthcare system in Alberta. All my thoughts. I've finished all your thoughts.
Okay, folks, let's get started. Online, can you hear me? Yes, they can hear me. Awesome. Okay, so we're going to skip the scrolling paper because we don't have time, and we're going to talk about evidence-based public health. If you want to be keeners, you can sit down, get together with your group, and go through it and think about what Dr. Crone is talking about in her paper. We're going to talk about next is evidence-based public health and kind of what that means from a conceptual side and also from a practical side. So you're going to be working in your groups for your final assignments. So I'm going to spring this on you every now and again in class, whereby at least some work is going to get done with your group for your final assignment in class. That means that it's probably a good idea if you figured out some sort of communication, just getting some really blanks there, some sort of communication method for your group in class, okay? If your group members aren't in class, that's okay. You'll just work with the people that you have on what we're going to talk about. Does that make sense? Yes? A lot of blank stares. Okay. Basically, this just gives you the chance to work a little bit on your short report, your pitch presentation, and your final assignment sort of in class when the concepts are a little bit fresh. So the first question we have to ask ourselves with evidence-based public health is what the heck is evidence anyway? So this is from Perchetnik's paper from 2004. that I'll post on Blackboard. You can read it. Basically, it's a glossary for evidence-based public health published in the Journal of Epidemiology and Community Health. So he says that in the broadest sense, evidence can be defined as factors of testimony in support of a conclusion statement or belief and something serving as proof. How do we feel about that definition? Does everything need to be SAS for to have evidence?
I was just going to say it doesn't have to. I was going to say it doesn't have to support a conclusion. It could release it.
Okay, so evidence could refute a conclusion. Good. Yeah.
Has to have a practical component to it, like technical versus clinical.
Okay, so evidence should have some sort of practical aspect. Okay, and then the statistical versus clinical. That's sort of really in the realm of our public health medical kind of jargon. In law, does that matter? Legal evidence, does it matter whether it's statistical or clinical? Not particularly, no. Okay. So these are just things to think about. We can have a really broad thought about evidence. It doesn't all have to be, you know, epidemiological cohort studies showing the impact of this and that, right? You could just ask some expert and say, hey, what do you think about this? What does your expert opinion tell you about this? So in the paper, they sort of talk about how the generic definition is a useful starting point, that it lacks context. So it just says, it doesn't specify whether this is a public health topic or a legal topic or a topic that intersects with, you know, First Nations and law and public health. Our notions of evidence might change depending on the context. And it doesn't specify what counts as evidence, when, and for whom. So it doesn't say, you know, this is evidence and this isn't. And that's kind of important when we're trying to think about evidence-based public health, right? We need to know what counts, because if we don't know what counts, we might bring things forward that nobody cares about, and on the flip side, we might bring things forward that nobody cares about, and we might use the wrong type of evidence to make our point, which might not work. Do you think this happens in public health? Yes. When? Why? What sort of evidence public health or evidence argument for things like pipelines? When we talk about public health evidence and pipelines, what are the sort of different types of evidence or different ways of thinking about evidence that generally speaking get bandied back and forth?
Use like past examples. For pipelines, the pipelines are worried about spills, so they give all these evidence of all these spills that have happened.
Okay, so more broadly, what is that? What are those spills doing? So yeah, we have some sort of evidence to say that there's environmental damage, right? And on the flip side, we have some sort of economic evidence to say, no, but we really need this for the economy. And we're trying to balance those two things, right? Some people are saying the economy is more important than the environment. Other people are saying the opposite. This happens all the time in public health. Same thing. We say, well, no, we really need to prevent this disease, right? We really need to prevent type 2 diabetes. But people say, well, yeah, but it's going to cost too much, and we don't know how to do it, and so on and so on. Right? So we have these debates about evidence. It's very rare that it's sort of like, this is what we need to do, and then we go about doing it. That doesn't happen very often. So what's evidence-based public health? This is for Chetnik again. As a public health endeavor in which there is an informed, explicit, and judicious use of evidence that has been derived from any of a variety of science and social science and evaluation methods. So this gets us a little more narrow. Who's sort of a little more comfortable with this than our other definition of evidence? A little bit? Why?
It's more directed towards health rather than just evidence in general.
Okay, it's a little bit more directed to health. Probably people are a little bit more comfortable with sort of the science, social science, and evaluation methods. Those are comforting words to us. We sort of go, oh, okay, I know what they're talking about at least a little bit, right? What else is interesting about this? What did we talk about last time in terms of mandated public health? We talked, sorry, that's that question. I'll rephrase that question. In terms of the mandate of public health, I sort of see the term public health endeavor as leading us to think about what the mandate of public health is. Right? They're sort of trying to say any sort of public health endeavor, any activity that falls within the mandate of public health, where we're using evidence in an informed, explicit, and judicious way in a specific type of sort of scientific methodology. That's pretty comforting. Okay? Does that help you with any of your assignments? No. So then when we think about public health endeavors, what are our big public health endeavors? What would be give me examples of the four most important public health actions that have reduced overall mortality in the population since forever? Sanitation, for sure. Immunization may be one. Yeah. What else? Education. Had this debate last time. Is education a public health endeavor? Health education. Okay, so some debate there. Smoking cessation. It's a big one. It's a big one. Okay. What's coming up next for public health? What are our next big challenges? So these are our top four: clean water, sanitation, immunization, reduction in smoking. What's next? Healthy lifestyle. What does that mean? Okay, so physical activity, proper nutrition. What are all these things associated with? What health outcomes are these associated with? All of our chronic conditions, right? Obesity, type 2 diabetes, COPD, you name it, they're there, they're in there. Yeah? I know it's a first. Do you have a question? Okay. Sexual health, in what sense? Okay, that could be a big one. And might that be specific to context? What do we know about Saskatchewan's sexual health? How's HIV rates in Canada? What else? Chlamydia, gonorrhea, right? Is our sexual health good or bad? Bad. Okay. So that's something that's specific to Saskatchewan. That's really, really important, right? But might not be specific to somewhere else. Maybe if we go to, I don't know where, somewhere, that's not a problem or less of a problem. So we need to think about that. So I'm sort of going to give you, I'm trying to make this practical. And I'm going to get you we're going to try to think about 3 different types of evidence. And this should relate, you should be thinking about how this fits in with both your final topic and also sort of the papers that you've read in general. Okay? Because there's some things that we are really, really good at doing in public health, and there's other things that we're not so good at doing in public health. And this relates to sort of the types of evidence that we are comfortable with, that we collect, and so on. So is that online? Good. Okay. So when we talk about evidence and we talk about that sort of scientific method, I'm going to focus on 3 broad types of evidence. So the first is research that describes risk-disease relations, identifies the magnitude, severity, and preventability of public health problems. The basic question is, we need to do something about this. So what are sort of things that we might think, or examples of studies that we might think would fall under type 1 evidence? Yep.
Like following back over the safe injection site, where we can try to raise the downtown area.
Okay, so there's a safe injection site in Vancouver to reduce HIV rates. But so before we got to the safe injection site, how do we even know that HIV rates in Vancouver were high? Stats. What are the stats? Okay, so we use numbers like incidence and prevalence to tell us, is this bad or not? How much of this is out there? We're not really making a judgment about whether we need to do anything. We're just sort of saying, there's this much of there's this much HIV out there. There's this much diabetes. It doesn't tell us what to do. It doesn't tell us, it gives us a hint that maybe we should do something. But it doesn't necessarily tell us, you should implement a safe injection site to reduce HIV. Right? And that's what we're going to get to that a bit later. So what types of studies do we do for this type of type 1 evidence?
Observational studies.
Okay, we do observational studies. We do, what else? What happens when we pool a bunch of observational studies? Systematic reviews. We do meta-analyses. We do narrative reviews. Okay, we do review studies to sort of say, how, over a whole bunch of different individual studies, how big of a problem is this? Generally speaking, in public health, are we good at this or bad at this? We're pretty good. We're good at counting things, right? We're good at saying the incidence prevalence of HIV is this much, right? It's going up, it's going down, these things are happening, okay? We're pretty good at that, okay? Just the fact that there is very precise language around incidence and prevalence probably means that we're pretty good at it, right? There's specific terms that we use to describe different ways that a disease might manifest itself, or different ways that we might think about how a disease exists in a population. So now we know that there's this much HIV. There's lots, there's not a lot. There's lots of diabetes, there's not lots of diabetes. We know something about it. Sorry. So yeah, here's an example of type 1 evidence. Burden of total and case-specific mortality related to tobacco smoking among adults in Asia. Pooled analysis of 21 cohort studies, post-medicine. So here we're saying tobacco smoking is associated with substantially elevated risk of mortality. 2 million deaths in adults age greater or equal than 45 years in Asia in 2004. 2 million people died of smoking in Asia in 2004. Is that bad or good? Bad, big problem. We need to do something about that probably. It is likely that smoking-related deaths in Asia will continue to rise over the next few decades if no effective smoking control programs are implemented. So here they're saying, this is the problem, 2 million deaths. We need to do something about that. But they sort of glaze it over. They say, we need effective smoking control programs. So that's the second type of evidence we need to think about, is what should we do? Identifies the relative effectiveness of specific interventions aimed at addressing a problem. So this should be done. Give me some examples for tobacco smoke. What should Asian countries do to reduce smoking? Okay, so public smoking bans. Lots of places have done that.
Tax on cigarettes.
Tax on cigarettes. What else have we done here in North America and Europe?
Age restrictions.
Age restrictions.
Graphic images.
Graphic images on cigarette labels.
They should not sell loose cigarettes.
Okay, so no selling loose cigarettes. What else?
Limit where you can buy them.
Limit where you can purchase them. Don't.
Limit media, like ads.
Okay, limit ads. Limit who you can advertise to.
Don't allow kids to see them in the convenience stores.
Exactly. But don't show them behind the counter. Don't show them in convenience stores or where you can purchase. Okay, so some sort of prevention to say let's focus on younger populations. Now, we've done all of these things. Overall, we've reduced tobacco smoking in Canada by quite a lot over the last 20, 30 years. How effective is a public smoking ban? How many people stop smoking when you implement a public smoking ban? 10% of the smokers? 30% of the smokers? Any idea? So we might be more preventing secondhand smoke exposure than smoking and primary smoking, right? People who actually smoke.
Probably prevent people from starting.
You might prevent people from starting. Okay, but go ahead.
Also, over time, it removes the social norm, so you're no longer like if you reduce the incidence of people seeing it and being exposed to it and the casualness of it, like if you can't just casually smoke where you are, then you have to consciously leave where you are to smoke. Like over time, it erodes people's interest in smoking. If you can't be in the meeting and smoke anymore, and you start fighting something, so there's a reduce the productivity. Okay, and do we have strong evidence for that? Don't know. But what's happening right now? What's the big debate? What's the big new cigarette product that is exactly that? E-cigarettes, right? That's exactly the public health argument that we make with e-cigarettes as public health. We say it's not about the fact that
there's no secondhand smoke exposure and all of these things. It's about the normative nature of it. It's to say people are smoking in public places, even though there's no secondhand smoke, that brings cigarettes to be a little bit more normal than they were before because you couldn't smoke before. But there's other public health people who are saying, yeah, but we have no evidence of this. There aren't good studies that show that that's actually true, and that actually people might take up smoking more because they're smoking in because people can smoke in public places. So this, I would say, is a really big challenge. Is to say, we need to do this. This should be done. And related to your assignment, this is exactly what you need to do, right? You need to come up with some type of intervention that's going to address the problem of how bad it is, right? Whatever your topic is, you have to say, and here's my intervention, and here's why I chose that intervention. So here we're intervening. There's lots of different ways that we can intervene. We talked about public policies in terms of smoking bans and in terms of sales restrictions. We talked about lifestyle change in terms of addressing youth smokers. We talked about, what else did we talk about? I don't know. There's lots of other things, lots of other broad types of interventions that we can have, right? So a public health intervention should be defined as something that is applied to many, most, or all members of the community or population, with the aim of delivering a net benefit to the community or population, as well as benefits to individuals. So what's important about this definition? There's two kind of things happening, and immunization is our classic example of this.
Net benefit.
We need some net benefit. The major net benefit that we're looking for is community or population, but we also should have a little bit of net benefit to the individual. It doesn't have to be a lot, but it has to be a little bit. Okay? So good examples of that are immunization. Seatbelts are another really good example of that, right? Very small net benefit to you as an individual, but massive population benefits. Okay? So this is something that you should be thinking about when you're thinking about your intervention for your assignments. And then we need to think about evaluation. So a process that attempts to determine as systematically and objectively as possible the relevance, effectiveness, and impact of activities in light of their objectives. So Thursday last week, it's Chris, right? Yeah. So Thursday last week, Chris was talking about his systematic reviews, right? He gave us his summary in the seminar of systematic reviews, how to do a systematic review. Really nice presentation. Talking about randomized control trials and talking about sort of hierarchy of evidence. To say, randomized control trials are the best single study method, then, fill the blanks here, then what's next? Analytical observations, cohort studies, right? Then case controls, then cross-sectional studies. This is sort of our typical hierarchy of evidence, right, that we use. But I don't necessarily disagree, but there's things that we need to think about in terms of how we evaluate or what we can evaluate in terms of public health. Could we do a randomized control trial of smoking bans? We could do a thought experiment. We could design one, but it would be really hard to implement. Okay? So a lot of the thinking around the evaluation of different population level public health interventions, we need to think about different methods, different types of designs to get us to evaluate something that's actually relevant, right? Let's put a smoking ban in and evaluate the impact. And we talk about three types of evaluation, process evaluation. So this is sort of what happened in the intervention. Program planning evaluation is coming back to you. Yes? Okay, good. So it's assessment of the process, what happened in the intervention, did it go as planned, what didn't go as planned, what was good, what was bad. Impact evaluation, the initial effect of the program on proximal targets of change. That's our bike share study right there, right? Impact evaluation, what happened 1 year or 2 years after. And then outcome evaluation, consequences, consequent effect of a program on health outcomes corresponding to program target. What's happening with bike share right now in Montreal? It's probably going to get shut down because they don't have any money because not enough people are using it, right? So despite our impact evaluation showing that it might potentially work, our outcome evaluation would be it got shut down, no impact. Okay? So these are things that are important to think about when we're thinking about evaluation. So here's what types of evidence: global effects of smoking, quitting, and taxing tobacco, New England Journal of Medicine. So New England Journal of Medicine, does that ring any bells? Why? What is that? What is the New England Journal? Medical journal, the #1 medical journal, pretty much. Okay? So if you can publish a paper in there, you'll have a pretty good career probably. But here's an evaluation of global effects of smoking, quitting, and taxing tobacco. So what happens when we do this? Well, what do they say? No specifics in their conclusions. Do taxes work?
Yes.
Yes. But they basically say there's a lot of problems and you can try to stop this at every level, but taxes probably work. Okay? And that's their conclusion from New England Journal of Medicine paper. Okay? And this is sort of, basically the call is, again, saying to those, trying to promote to those countries that haven't taxed cigarettes, that haven't implemented these types of interventions, saying, you need to do this because the full eventual hazards of smoking cigarettes are really bad, right? A lot of people in your country are going to die. And then we have this type 3 evidence. And this is a little bit different. This is, again, speaking to context. So how something should be done. So information on the design implementation of an intervention, the contextual circumstance in which the intervention was implemented, and information on how the intervention was received. So how might this be different from our type 2, our effectiveness of an intervention? Any ideas on that?
Something might need to be implemented in different ways based on the context where you're implementing it.
Okay, like what? Give me an example.
So another working on the implementation of lean in Saskatchewan, and they're looking at how lean is implemented in different parts of the hospital and why it's effective in some areas and not effective in other areas.
Okay.
So, and what contextual factors influence that effectiveness.
Exactly. So there might be different sort of hospital areas or different types of hospital areas that would be more able to implement it or better able to do the complete process than others. For my two groups that have TB in Saskatchewan and chlamydia gonorrhea in the health region, what's important about the context of Saskatchewan and the health region that we need to think about in terms of implementing public health interventions? Yeah.
There's the practical side of TB and the fact that it's provincially distributed, but we're a very regional sort of province in terms of the north is a very different demographics than the south. We have some populations, including Aboriginals. We have federal land where are preserved, and then there's issues there within provincially. People move, but we like to put these boundaries in early there, so it would be very different than someone who's just trying to get isolating out of the top people.
Okay, good. So exactly, we have sort of geographic administrative circumstances that make the context different. The north, for example, versus the cities versus the rural areas that we might want to think about. We have other administrative things like financing and so on that are important. We have socioeconomic and ethnic things that might make it important, right? Aboriginal populations, low-income populations in urban centers that might change how we implement an intervention. Okay, and these are things that we need to consider when we're proposing an intervention, right? We can't just say one size fits all. This is just going to work for everybody. We need to think about how it might be different for different people and how to best go about implementing and evaluating that type of intervention. Okay, so here's another paper from Tobacco Control Research. Socioeconomic disparities in quit intentions, quit attempts, and smoking abstinence among smokers in 4 Western countries. What might this little results section tell us about implementing smoking interventions in Western countries?
Intervention didn't seem to take, was not very good at correcting for inequities based on the fact that you're seeing stronger effects amongst higher educated more affluent groups than others.
Okay, so more effects for higher educated and more affluent, definitely. That's something we think about. Yeah.
Higher education and
Exactly. Okay. Those are factors. What about UK and US versus Canada and Australia? Isn't that a weird finding? How would you explain that? Why are US and UK smokers less likely to intend to quit than Australian and Canadian smokers? So maybe there's more smokers in the UK and US, it's more normalized? Yeah? Okay, higher Aboriginal population might explain it.
They're more expensive in Canada and Australia.
Cigarettes are more taxed in Canada and Australia. So other policy differences other than taxes, right? Maybe the public smoking bans have a different sort of feel. Maybe there's harsher limitations on selling and display of cigarettes in places where you buy them, right? But that's a strange and interesting finding that we need to think about in terms of context, right? Canada, even between Canada and US, there might be differences between how we go about implementing broad public health policies, right, or legal changes. Okay, so here's your homework for now. So get into your working groups for your assignments. So this means whoever is here in your assignment today, if you're with your online group, get together with them through whatever means you have decided to get together with them, whether that's Google Hangouts or Skype or whatever. And what I want you to do is find one example publication of each type of evidence for your topic. So I want you to find one sort of prevalence type study for your topic, prevalence incidence type study for your topic, one what should be done, so one public health intervention study for your topic, and I want you to find one sort of study that shows variation in intervention effectiveness by some factor, some socioeconomic factor, some factor that might be relevant for your topic. Okay? Ready? Go.
Point it everywhere.
If you don't have it ready, ready right now.
We don't pick that up. We were just like, hey, climate. No, you probably we can talk to you if you like to do it.
Okay, you're in group 2.
The first
Somebody else.
Yeah. New teammate.
developing some services the highest are verified are in North Europe and the US, and the lowest are in Latin America and Africa. If you choose one that has the highest budget, so like North Europe, and we can choose Europe. So the first, like, because I'm just looking at that else. So North Europe and the US have the highest rate. So you can choose like
Europe and my favorite invention was you can get funds through medical surgery and then taking off all the drugs that are drugs so a lot of these people talk to people on those pages how to make drugs and then every day. And then if you don't follow any of the drugs, and then you do some we should pick them in a study for medication routine, like consistently, but fun things for the country.
okay, so why don't you find that? So they'll find like a medication okay, yeah, so this is our first.
That's good news, but
Yes.
yeah, but fun is
I also found one.
There's good pads on it too. Quick pads. There's actually a software review on that. Oh, this one's better. Why does quick pads or soft quick pads? We have so many credentials. Well, it doesn't have to be interventions.
So like another thing is there's like acute phase and then probably the chronic. Yeah.
Here's one on pharmaceutical pharmacologic treatments for this.
Sorry? No.
Why don't you feel like you're spending helping around the message that you
So,
So like the intervention, like for the intervention, I was focusing on like preventing the problem.
Are we focusing basically on intervention?
Sorry?
Are we focusing on intervention?
Yeah, like just like preventing fall related to fractures.
Does the try to prevent fractures in hospitals and care homes?
Yeah, like
No,
I just found something similar. Like, should we focus on elderly in hospitals and like nursing homes, or like just like
Young adults?
in general, right? Like dogs.
Or young adults because
but even being implemented, and then that's when you intervention like that.
I think this is great for the older folks because they are more likely to survive before.
Yeah, we are focusing on the older group, so we just don't know if we want to focus on like elderly in hospitals and nursing care homes, or like just in general, like in the community, or like independent elderly. So yeah, we can look at this.
Geographic areas, socioeconomic,
Well, like this article talks about how there's like exercise programs for like balance and strength training, and there's multifactorial interventions like maybe we should go with multifactorial ones because if you have like a specific time, it might not work anyway. Like balance and strength training is so cool.
It's great because it says that multifaceted interventions work in hospitals, but more evidence that they're effective in care homes. So there's your
Okay. So if you do that as part of it, just doing this
Well, maybe it doesn't.
Yeah. 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 That's why I got this Where are you? Oh, yay. Thank you. Oh, my God.
Because like even though they're under supervision, yeah, like even though in like nursing homes they're under supervision, but like I remember I used to volunteer like at one, and like it's not like they're always around nurses, right? Like in their rooms, like most of the time they're alone with their head off.
And if you talk to your kids and you're like you're like,
Yeah.
right? So it doesn't matter if you well, it's better if you talk really quick, but just that you're not so long.
Yeah.
Most times we can do operations for them for stuff. Yeah, we get to do surgery at the end of the day for them.
Yeah.
This is all talk about the overall risk of overall incidence of prevalence of ritual intolerant racism.
Which region is that in? Does it say like a state or just say like that? Or then so we can just say that. I don't know where it is. And then we're doing multifactorial for implementation. Exercise is the only intervention that reduces the risk of falling and falling. All other interventions such as home habits, supplementation, show an effect only on what is we have to put like
we could group these factors we could group them, like we could have exercise, we could have for surgery, we could have for drugs.
Yeah, but isn't like multifactorial? So what, like the multifactorial probably have a fixed like number of it. So yes, specifically like we can make our own like multifactorial, like it's already there, and then we can say that in combination with like another type of intervention.
That's the general maybe like
yeah, like it's just like it has like a completely clear it off.
Yeah, the two multifactorial is a unit review, and then every intervention that included more than one intervention. So they're multifactorial, probably a mix of different multifactorial interventions. So that's we use that one for whatever the study. So we just need a 2-3 study. Yeah, I can't do the same with much as we do articles.
Information has design implementation for interpretation.
And then it's
It's like the implementation, right?
Like a study where it works in one context but doesn't work in another context. Or look at the context.
Like comparing them.
Isn't it a study?
Wait, did you guys find one that said multifactorial interventions are successful in some but not in all Sexual assault prevention college.
That's just based on statistics. Like it should be one complex thing.
And then there would be four
and then try to your context or whatever.
Yeah, this is what it's doing. If we actually choose nursing home, then how do you actually force it to change, especially in the city? Better what? Community?
Yeah, I saw that.
Right, but you can find effective interventions, right? But then forcing a nursing home, unless we say this, like from a public health perspective, forcing nursing homes to change, to implement the intervention, right? They're private organizations, especially in the United States. So you can recommend that they do something, but from public health perspective, then our intervention is just releasing guidelines, pretty much, right?
So, screening is
or have change Medicare reimbursement so that there's a clear system based on the benefits that reimburse more if they implemented risk reduction, or even if they implement risk reduction policy.
Going there. So
Yeah. No, we're not gonna get much of that.
Oh, really?
It has to be like, it goes beyond like just making recommendations and like sharing public health That's where this concept specific part comes out, right? Then you can recommend how to implement it.
There was one in the county that they depends on something in the community. I think of it. Yeah. Yes.
I know. Yeah. So the program is for them, basically, like our intervention is for the workers of the
That's something that can get you a little bit further away from more narrow individual people accessing and more towards population level intervention. These services exist.
Even if they have that's why we have to make it okay, what I mean?
Basically, like a meta-analysis that shows 50 intervention works. How's it going? Okay. Right, okay, that's great. That makes sense.
Well, here it says effectiveness and implementation aspects of interventions. So prevention falls on the elderly people in long-term care. Is that the one that you found? Because that's what we're looking for, right? Like,
Right. Yeah, that's fine. Have you found any papers by Jennifer Olaf? She's someone to look at.
Yes, it is inconsistent. Communication and she did not find the significant on the call after.
Hello folks, how's it going? Questions? What's your type 1 status? Okay, so American data. I know we generalize that's Canada.
because we searched up like just like the factors that really come out in the States and then in Europe, so we are thinking of
I guess you guys should probably need to.
yeah. So either North Europe or the States, but our focus will be the States.
Okay, is there data for Canada? Can we try to find it? Okay, good. So that's just like, just try to find it. You're always going to get that question. Right? Does that mean? Do you have that data? Most of the time we do. Sometimes we don't. Like two questions. Or what are examples of potential interventions you look at?
Well, there's a lot of
Okay, good.
Yeah, there's also like multi-factorial interventions, but we're still trying to see like what exactly it consists of. So it's one.
Okay, good. And technique?
Yeah, we're working on that.
So what do you have?
The different interventions that they work on the more
Okay, good. I would
Will it be difficult to meet in the community or in the
good. So yeah, the sort of scalability or generalizability of nursing home intervention to the general population. Can we make that jump feasible? I would say maybe another thing to think about is sort of affected by age, even within typically a multi-level population. Like our new intervention due to the effectiveness of intervention for those 65 to 75 and older than 75. I don't really know what you're thinking about it. So that's amazing. Oh yeah, Lawrence Brawley. He's a TIM researcher here at UofS who does falls prevention research. So he might be someone to send an email to or at least look up his papers. Lawrence O'Leary is this guy, Brawley. B-R-A-W-L-Y.
Okay, folks, 2 more minutes.
Yeah.
marking abstracts on the issue or
Yeah. We can meet up like this week.
That's okay.
I don't know. Doesn't matter to me. Tomorrow? Friday? Oh, yeah, Friday's fine. Now it's Sunday.
Yeah, that's all right.
Yeah, infectious, right? Wait, yeah, I have copies. Yeah, so Friday's fine.
Friday one?
What's fun? Good, yeah, I want to. Yeah, is that it? Well, just let us know, like I said. Yeah, where?
You want to send an email about this?
Yeah. Yeah, I'll make a Facebook group. It's going to be
There's something to do.
One more minute.
Friday, the 16th?
Yeah.
Yeah, I'm good.
At 1.
You can after class. As many as you want.
So what? Oh, I don't know what it's like. The abstract article. We can discuss it on Friday.
Okay, folks, let's bring it back. Okay. So, are there any questions about the types of evidence? One thing that I got from most of the groups was sort of how to distinguish between type 2 and type 3. So kind of what I'm looking for with type 2 for your assignment in particular is that you will come up with maybe 3 or 4 or 5 different potential interventions that you've reviewed from in the literature, and you'll pick one. And you'll give some justification as to why you chose that one intervention. And following that, you will... Following that, so following the selection of one intervention, you'll look at whether there's contextual, socioeconomic, other types of factors that might influence the effectiveness of that one intervention that you've chosen. You don't need to go and look at sort of type 3 evidence for every single intervention, only the one that you've chosen at type 2. So it kind of goes by stage. You figure out your type 1, how bad is the problem, type 2, what types of interventions are out there and which one are we going to choose, and type 3, given the context of our sort of country, province, city, our economic system, our socio-ethnic distribution in whatever area we are, how might that influence our intervention, right? So last year, for example, one of the groups did effective control of Ebola in West Africa. And their number one intervention was actually education. Because they basically said that, you know, something like 70% of the population can't read, but they can't get the messages out. They can't even do public health messaging because people can't even read. So that was their main intervention for effective control of Ebola. Right? That's totally contextual. That wouldn't be the case in lots of other places. Question?
So this group project and coming up with an intervention for what topic we pick, are we allowed to come up with our own intervention, or do we need to use one that's already in the literature?
Yeah, that's a good question. So you can either come up with your own intervention or you can use something in the literature. My suggestion is, if you find something that's shown to be effective in the literature, don't reinvent the wheel. Okay? There's lots of studies out there that show effective interventions. If you find something that works that's published, don't reinvent the wheel. Okay? Use that intervention. You're going to have to find type 3 evidence. You're going to have to go through that process regardless. So yeah, you don't need to do that. But having said that, one of the things that I'm trying to get all the groups to think about in terms of their intervention is think about that definition of where'd it go? Of intervention, public health intervention. Okay? So here we're thinking about two things, right? Impact at the community or population and benefits to the individual. So try to think about your intervention in that context, right? It's really easy to come up with interventions that affect only individuals. It's a little bit harder to think of interventions that are going to have a population or community impact and an individual impact. Okay? So that's where we're trying to go. We're trying to push ourselves a little bit further to think, okay, how can we think about intervention in this context, right? Rather than just sort of individual access, behavior change, or that type of thing. Or screening or what have you. Okay, so I'm not going to dwell on this, and we're going to finish early, but this is already posted on Blackboard. Basically, this is sort of a guide for your for evidence-based decision-making for public health practitioners. Many of you people will become public health practitioners. And basically, it just sort of talks about stages to go through when you're trying to develop some type of evidence-based public health decision. This is exactly the structure of your assignment. Develop an initial concise operational statement of the issue. Here's an example. Determine what is known through scientific literature. These are our types of evidence. Quantify the issue. What interventions are plausible? What are the options for our intervention? Are they policy, economic, social values, blah, blah, blah? These are sort of picking out the types of interventions that you might want to think about implementing. Develop the intervention. What is it going to look like? And evaluate the intervention. Are you going to do what type of evaluation? What type of study design you're going to have? So on and so on. So both the types of evidence piece of evidence-based public health and the stages of evidence-based decision-making, I would recommend highly that you sort of use these as a guide in your process for developing your intervention or developing your project, right? Because it's really easy to just sort of puddle along in PubMed and on the search engines and find articles. But if you sit down with your group and you sort of try to put together the plan of, okay, what do we need to do in what order and what does that look like, and then you try to go about doing that plan, it'll be much, much easier than trying to just search around in the literature. Okay, so that's something that I would highly recommend you doing. There's a whole bunch of other ways to think about implementing evidence-based decision-making. The one that the Brownson paper, I'll put on Blackboard. This is the National Collaborating Centers for Methods and Tools, and they have another strategy for evidence-based decision-making: define, search, appraise, synthesize, adapt, implement, evaluate. Right? We can see sort of the same themes coming along. Find what you're trying to do, search for it, appraise the evidence, synthesize the evidence, adapt the evidence to your context, implement an intervention in some type of intervention, and evaluate that intervention. Okay? So there's lots of tools out there to help you through the sort of conceptual process of doing your project. And essentially what your project is using evidence-based decision-making to propose a public health intervention that will impact people's health. That's your project, right? So I'm just basically trying to get across that there's lots of different tools that can help you organize your thoughts, give you sort of a process to go by when you're doing that. Does that make sense? Okay. Any other questions, comments? No? Online? Any questions?
Yeah, good. No.
Well, done. Okay. Thanks, everyone. See you next week.